The exemplar that I'm going to be discussing in this presentation is osteoporosis, which is highly related to hip fractures. And if you want to, the pages that I have expressed for you to read, if you look at chapter 70 in your Med-Surg ATI book, starting on page 445, it's only about 3 pages worth of information, is what you need to be referring to along with these PowerPoints and the presentation. So with osteoporosis, and this is related to mobility in a big way, because a lot of people that are diagnosed with osteoporosis one of the cures, or I guess I should say nursing interventions that we would teach our patients to do would be to exercise. So risk factors associated with osteoporosis: increased age. Female sex is typical, although it can occur in men. White or Asian race, positive family history, and typically what you're going to see with this is the women have a very small, thin body build or small frame. Okay, they have a low intake of calcium. They've had prolonged immobility. Remember that what can happen with immobility is it can cause the depletion of calcium. Excessive alcohol and caffeine intake and cigarette smoking are also risk factors. Elevated stress, and then long-term use of corticosteroids, anticonvulsants, and thyroid hormones or thyroid replacement. So this is a typical picture of what somebody with osteoporosis looks like. The A is normal bone. Then we get into osteopenia, which is starting to lose some of that bone. They can see that. And then osteoporosis all the way to the right. The gender differences in bone density is that women are at an increased risk for loss of bone density. Okay. Meaning me, being a woman, accumulate less bone mass than men, and we typically have smaller bones. Okay, when we go into menopause, we have a loss of bone density, and with men, they lose testosterone gradually, and their bone density is lost at a slower rate. Okay, prolonged lactation results in bone density loss, so that's a reproductive factor. And women usually live longer and have a greater risk for more bone loss because we do live longer. The pharmacology and nursing responsibilities associated with osteoporosis. Biggest thing is that we have to make sure that patients get adequate vitamin D and calcium intake. I've said this in previous lectures that we need calcium we need vitamin D in order to assist with the calcium absorption. Decreased rate of bone reabsorption occurs as we get older. So the classification of what you're going to see in special considerations with medications, they're going to possibly put them on a bisphosphonate, such as Fosamax, Actarone, and you do need to kind of look at these. I guess I should be saying the generic names. Alendronate is Fosamax, ricindronate is Actonel, and then ibandronate is Boniva. I'm sure you've seen commercials out there advertising these. Also, they might put them on selective estrogen receptor modulators, or SERMs. Okay, they give them the benefit of estrogen without the disadvantages. Calcitonin, it's safe, but it's less effective, and they according to the studies, it shows a decrease in spinal fractures by up to 33%. Hormone replacement therapy. This is something that's no longer approved by the FDA for the treatment of osteoporosis, but in the past it has been used. The National Osteoporosis Foundation recommendations that we need to provide education to all women concerning the risk factors. They're going to do bone mineral density tests on them for any woman who has had a fracture, and then BMD testing for any woman greater than the age of 65 who has any risk factors for disease development. Diet is key. Adequate calcium and vitamin D. You'll see calcium chews and different things like that for people to take. Need to increase the intake of that during adolescence and in the middle years. So get them to drink milk. Where do we get vitamin C from, or vitamin D? I'm sorry. Calcium from. You can get it from dairy products, broccoli, canned salmon. And in your book, it talks more specifically about what and where you can get vitamin D from as far as your diet, and it's in there in your on your pages in ATI, so you can look at that. But Those are the main ones that you're going to see. Encourage weight-bearing exercises and reduce and eliminate smoking. Try to reduce or eliminate the consumption of alcoholic beverages, caffeine, phosphorus, because phosphorus reduces the calcium, and that's what you get, a lot of phosphorus from the sodas and things that people drink. Hip fractures occur, and this is why we threw in hip fractures right under osteoporosis. Hip fractures people with hip fractures have a high hospital admission rate. Causes a lot of time from falls. A lot of times people that have hip fractures, you will see that they will state they don't remember falling or doing anything, but they heard a pop and then they fell. Due to a diagnosis of osteoporosis, a lot of times they'll break and then they will fall. So it lists the different causes on there, unsafe environment, history of falls, things like that. Hip fractures include the upper third of the femur. You can have intracapsular, as the head or neck of the femur, the top part, or the extracapsular, which is that trochanter or greater trochanteric region. The assessment of somebody that has a hip fracture, you're going to see the injured leg is going to be shorter. It's going to be externally rotated or rotated outward. They're going to have extreme pain when they do move, okay? And it's usually in the hip and the groin or the medial side of the knee is where they're going to experience pain. If you have an intracapular fracture, you may not see shortening or extensive pain. And the treatment, I mentioned this a little bit earlier, is to immobilize it, possibly do traction, and then possibly do surgical repair as well. Types of surgical procedures dependent on the type of injury and the patient's condition. And whether they have any pre-existing orthopedic conditions, the surgeons are going to look at it, on a case-by-case basis. Post-operatively, patients may have weight-bearing status that differs depending on the type of surgery that they did. They may not be able to put all the weight down on their leg. Pain management, they're going to need pain management to improve walking and mobility. So that's a big key, almost a number one, or one of the most prioritized nursing diagnosis on anybody that has a fracture is going to be pain, okay, that we have to keep that under control. They're going to have a risk for infection, especially if they've had a surgical intervention, because we've opened up those tissues. The doctor's gone in and manipulated the area, and so we need to make sure that they were monitoring for signs of infection, washing our hands, things like that. Risk for delirium. Delirium is confusion, not I've seen instances where patients just aren't awake for a lot. They're not making a lot of sense. They are disoriented, and a lot of times this could be due to pain medication. It could be due to the anesthesia that the patient's on, and the fact that they're in the hospital and out of their normal environment. Falls in regards to the older person mostly occur during normal routines. Like I told you earlier, sometimes it may break before they even know it, or they slip while they're walking into the kitchen. They catch the corner of a rug, something like that. Hip fractures is the 7th leading cause of death in persons over the age of 65. Individuals that have hip fractures, the morbidity rates are excessively high. A lot of times, depending on their age, individuals do not recover well from these, and it leads to death. Cost of a fall is over $19 billion a year, and that is expected to rise. Okay, and so it says after a hip fracture, 1 in 4 older people are institutionalized at least 1 year. Many never return home. Fall prevention is the key for us. Safety is the key, and you'll hear us as instructors harp on this, making sure that you have gait belts on and that wheelchairs are locked. You don't leave your patients alone if they're at risk for falls. So the key to fall prevention is to assess every patient as closely as possible and keep them from having a fall. So the goals are to recognize the individuals that are at risk, to identify and correct the risk factors, and to improve balance, gait, mobility, and functional independence, and then reduce or eliminate the environmental factors contributing to the fall. I talked about, if they're living at home, do they have dark corners? Do they have rugs that are sticking up? Do they have cords everywhere? What are those factors that can contribute to that person's fall? And those are some of the things that we have to, as an educator, we have to assess for. This concludes my lecture on osteoporosis and hip fractures. Thank you.